Good morning, ladies and gentlemen. It's an honor for me to speak about high hyperopia challenge and limits. It is refractive surgery, but not intraocular lenses. The hyperopia in refractive surgery is a challenge. The following points are absolutely important: steepening of the corneal center, untreated central zone of 6.5 till 7 mm, peripheral ring zone ablation from 7 till 9 mm, 10 mm flap diameter, preoperative radius not steeper than 7.4 mm, preoperative K value not more than 47 diopters, corneal thickness more than 500 μ, two types of hyperopic eyes you have. The first is a big eye with radius higher than 7.9 mm. It's flatter, so maybe you can correct more. And a smaller eye, in the average more hyperopic with radius lower than 7.9 mm. They are dangerous for getting maybe keratectacy. Refractive ablation limit plus 5.5 diopters. Here you see the different kinds, different techniques for different grades of hyperopia: deep ALK, AK, PRK, LASIK, Intex, and the LTK, DTK, and CK. More than plus 6 diopters or 5 diopters, the phakic IOL and an ICL. We have 33 high hyperopic eyes, more than 2.5 diopters, between 1st of July 2016 till 30th of December 17. LASIK was done with a Schwind Cariaso Paracare microkeratome with 10 mm flap diameter and 103 μ flap thickness, and the laser ablation was done with excimer laser MEL-80 from Carl Zeiss Meditech. Stability, predictability, safety were analyzed. Here you see the patient population: pre-spherical equivalent plus 3.38 plus minus 1.57, and 1 year later is the refractive outcome minus 0.03 diopters plus minus 0.53 diopters for the spherical equivalent. The preoperative spherical which you see here, in the average, it is from the main people were 4 diopters. Stability, spherical equivalent over the time. It is not quite stable. It's a regression after 1 year from about 0.5 diopters. The predictability is always very interesting to know for the patient, and it is to know for the doctor. You can see here more than plus 3.5 diopters, there starts an undercorrection. And the refractive outcome after 12 months in 47% plus minus 0.15 diopters. And the safety change in corrected distance, visual acuity, you can see here. After 1 year, 52% is unchanged, and after 1 month, and after 12 months, unchanged 24%, but gained 1 line in 52%. The cumulative uncorrected distance visual acuity you can see here. The green line is 1 month, the red line is 1 year. 20/20 or better after 1 month, 13%, but after 1 year, 57%. The preoperative corrected distance visual acuity against the postoperative uncorrected distance visual acuity, the green line is 1 year, the red line is the preoperative spherical visual acuity. 20/20 or better is 57%, and 20/25 is 67%. Stability, time after surgery, you can see here, it is an uncorrected distance visual acuity over the time. There is a regression from 0.75 diopters. And the attempted change in the cylinder were achieved, you see, in opposite to the normal hyperopia, the cylinder is quite stable in and after the ablation. The preoperative 1 month against the 12 months double angel cylinder, it is preoperative. You see here all the cylinders in a special plot, and this is the cylinder plot after 1 month, and this after 1 year, and the cylinder plot is very, very stable. In summary, we can say the complications are regression, epithelial ingrowth, flap folds. Only 3 enhancements were done. Retrospective study over 16 months showed good stability, good safety, good predictability. Eyes more than plus 5.5 diopters are not in this study. The preoperative K value of 47 diopters and the radius of 7.5 millimeter are the limitations, because after the correction of 47 diopters, you come more than 50 diopters, and that is the range to the keratoconus, and with the radius, it is the same. In conclusion, it is now the same. Futurist femtosecond surgery for hyperopia we will see. Also, the additive ablations just done in Switzerland, we will see in the results of operated hyperopias. Thank you very much for your attention.